Um, okay, well, in the interest of making the best use of time and our time with Doc, and I'm so delighted to have Doc here. So I'll just start by, you all know me, which is great. I don't have to do too much of an introduction for myself, but because we're recording, I'll say hello. I'm Day Hagel. I'm the director of Mental Health Wilderness First Aid. Um, I'd just like to always say that what Mental Health Wilderness First Aid is, we provide mental health first aid training that is specifically oriented for folks who live, work, and play out in wilderness and remote areas. So that's a lot of fun. We do a lot of work with search and rescue teams, outdoor educators. We have lots of polar guides come through, First Nations communities, tree planters, lots of outdoor industries. I just ran a program for the first time on a ship. It was a lot of fun. I was out with Maple Leaf Adventures, who runs big catamaran tours and sailing trips up and down the coast all the way up to Alaska. And so they invited me to do a little training for their folks during orientation. And so I got to be on a catamaran, which is first time I've ever taught from a boat. I've done a lot of paddling from a boat, but never this course. So we have lots of courses running through spring 2024. We are having, for those of you who have done a basic course, we're doing an upgrade course, upgrade to 40 hours. So you can upgrade your cert and get a 40-hour cert in June. That's going to be a lot of fun. I know Dawn's on that course. That's going to be great. And what else should I say here? Oh, if you are interested in past guest speakers, we have Doc here tonight. And if you weren't already aware, I'm going to drop in the chat for you. There's a link to our past guest speakers in case you're interested to check any of them out. So I'll just say welcome to Doc. So I'll read your bio off of our little website here. So
Sure.
Michael Doc Crawford started in medicine in 1985 as a medic in the U.S. Navy Marine Corps, serving as a critical care corpsman at do I say it Bethesda Naval Hospital?
Bethesda.
Bethesda. Thank you.
Yeah.
He was next stationed on board the USS Canopus, the AS-34, and worked both with the medical department and the U.S. Marine detachment on board the ship, where he earned the nickname Doc. After getting out, Doc worked at Tucson Medical Center as a patient care technician in the trauma intensive care unit. Doc has extensive wilderness tripping experience both recreationally and as a canoe and hiking guide. Doc is an owner, chief instructor, and the current curriculum director at Slipstream Wilderness First Aid based in Victoria, BC, where some of you are familiar with. Doc has been a Wilderness First Aid Instructor since 2005. He was an outdoor emergency care instructor and instructor trainer, as well as a member of and trainer for the Mount Washington Ski Patrol Association for 5 years. Doc is also a member of the Wilderness Medical Society and the Canadian Association of Wilderness Medicine. And I would also add to that Doc is a friend and also a mentor personally for myself, as well as for the Mental Health Wilderness First Aid program. So I've known Doc for quite a while. I think the first time I got a Wilderness First Aid cert with Slipstream, I think I was 17. It was a long time ago. Now back in 2004 or so. And then I recerted pretty much every 3 years. I would do a recert, not always with Doc, but with someone on his team. And then when I went back to school to become a counseling psychologist, and I ended up creating mental health, what became Mental Health Wilderness First Aid out of my master's degree with my capstone project. And I remember Doc actually came to a number of my early presentations and gave me feedback on how I could develop the program. And we talked a lot about what it meant to integrate mental health into a medical model first aid program. And I talk a lot about Slipstream in the different courses that we run too. So yeah, you've been no shortage of generous to me with your time and expertise, Doc, and I really appreciate you not only being here, but putting all of your energy into helping me develop my program over the last 5 years or so. So together we're going to touch on a bunch of fun things. The rights of medication as a risk management tool. I know Doc's got some info about that, and then we have some fun scenarios. So this is going to be quite an interactive workshop. Now that being said, if you are in a place where you really can only listen and you can't participate for some bandwidth reason or whatever, please don't leave. Please do participate in the breakout rooms. We can just throw you in a breakout room, and if you have to, you can just keep your video off, but at least it allows you to participate. But please don't feel like you have to sign out if you're having trouble with that for any reason. Okay, so a couple other housekeeping things. So I'm going to be helping run things in the background so that Doc can just focus on running the show. If you want to drop anything in the chat, I'll leave it up to Doc how you want to facilitate hands up, or if people can just unmute, or if you're going to look at the chat. I will bring your attention to anything in the chat that I think that you've missed that might be good to address right now. But also, if you folks have any tech issues or need to go out and in or whatever, if you need to send someone a message, you're welcome to send it to me so that Doc can just focus on the front page here. That being in mind, I'd like to invite you to open up your Zoom chat and please introduce yourself to each other and to Doc. Some of the nice things about these events are that you get an opportunity to network and meet folks as well. So yeah, introduce yourself, where you're calling in from, or what it is that you do, what brought you here. We are recording this event, as you have seen, and we will post it to our social after. It often takes me a while to edit the video, but I will post it at some point. So that being said, this is for everybody. If you at any point make a comment or you ask a question that you are thinking afterward, oh, maybe I overshared some personal information or something like that, you are welcome to email me. Please email me just in the next couple of days and say, hey, I'd prefer if you cut out that portion of my participation or something. That I'm happy to do that for you. Did I cut you off, Doc?
No.
Okay.
Not at all. Just so you know, I'm a little bit shy, Day, so maybe you could cut out all the times when I'm talking, and then
we'll just have the times when Daniel and Hattie are talking. Okay, great.
Yeah, exactly.
Okay, well, Doc, I'm very grateful to have you here tonight, and without further ado, last note, as always, the guest speaker's views are their own and may or may not reflect the views of Mental Health Wilderness First Aid. We'll see. Okay, Doc, I think over to you.
Sounds good. Hello, everybody. Hi, Daniel. I recognize you. I don't know if I've met anybody else here. If so, and I'm missing you, sorry, I see lots of students. We're going to talk about medications in the wilderness setting. And I always like to start off by saying that, I'm sure most of you are probably aware of this, I would hope, but the pharmaceutical industry has done an amazing job of normalizing medications, right? So much so that people don't really think twice about popping a pill for a headache or things like that, right? And what that can, the unfortunate part about that is it can lead to potential medication errors if we're not paying attention to this kind of stuff, right? So I'll start off first by talking about a few things that apply to all medications that come on a wilderness trip. But then I want to talk about the rights of medication next. And the rights of medication are basically a risk management procedure that we use in healthcare to try to prevent medication errors in hospital and in healthcare in general. And so it's a tool that I recommend that guides or people who lead trips in the wilderness also use to help try to minimize the likelihood of the chance of a medication error happening when you're on a trip. So what I'll do is I'll share my screen here because I have a slideshow. And let's see, share. Oops, not photos. That's not what I wanted to do. Share screen. There it is. Screen, start broadcast. All right, and then there's my lesson. Can everybody see my lesson there?
I could for a moment, then it disappeared. Oh, now it's back.
There's back. Yeah. Great. Awesome. So a few things that are important with all medications in the wilderness is one, any critical medications that are coming along in the wilderness, we have to make sure that we duplicate those medicines and then also put them in two separate places on the trip. So duplication, we just typically push that back to the client or the participant. And what I say is you have to bring twice as much as you would normally need for this period of time, right? And then I make sure that in my case, when I guide, I take half of their medication, right? And they keep the other half. But you want to make sure it's in two separate boats or two separate backpacks or these kind of things. That way, if we dump a boat and lose some gear or a bear drags a backpack off in the middle of the night, we don't lose the only doses of medication that we have for this patient, right? For this person. So duplication and separation. Another thing is, it's really common that when we bring medications in the wilderness, we put them in a separate container, right? So if you're gonna, sprinkle 20 ibuprofen out of a bottle into a plastic bag, you want to make sure that you label that bag properly, right? You should have the name of the drug, the strength of the drug, the expiry date. You should also write down the lot number. Medications get recalled fairly regularly, right? And so if you don't have that documentation of the lot number on the bag, 6 months or a year from now, you may not know which bottle that came out of if you read about a recall of ibuprofen in the news or something like that, right? So you want to be able to tag that. I also tell guides sometimes it's a good idea, if you're bringing lots of different kinds of medication, to maybe also just jot down the purpose of that medication on the bag, just using a Sharpie or something, right? And if you have different size people on your trip, for example, like a pediatric patient, as well as adult patients, you may also want to add appropriate dosages, right? If the medication is prescription that you're splitting up, take a picture of the prescription label with your phone. That way you have a copy of that label with you when you go on the trip as well. And another consideration about this, when you are repackaging medication, make sure everything gets its own bag or container, right? You don't want meds bouncing around and rattling around together, because if you say put ibuprofen in the same container as Tylenol, right? Some of that Tylenol or ibuprofen will rub off on that other medication. And if you have someone, say, for example, is allergic to aspirin, and they take one of those Tylenols that was also in a bag with some tablets of ibuprofen, they may actually have a reaction to that, right? An allergic reaction, because some of the ibuprofen's rubbed off on the Tylenol caplet or something like that. So you want to be careful with that kind of stuff. Another consideration is, do you have appropriate strengths of medication for different people on the trip, right? In the guiding industry, I talk about this a lot with, say, epinephrine, right? If you're guiding small children as well as adults, you need to have pediatric size epinephrine as well as adult size epinephrine on the trip, right? And that would apply to any medication that you're bringing for the group. Do you have an appropriate skill set required to administer the medication? It's pretty common in my industry anyway, that guides are taught to draw up medication, say epinephrine, out of a vial, right? And when I learned in healthcare how to give injectable medications, it was much more complex than I've seen being taught sometimes in these courses, right? So you really want to be careful and make sure your skill set is up to par. If you're going to give medications that require some sort of skill to give, skill beyond just giving somebody a pill for them to swallow, say. Make sure you store medications appropriately, right? Lots of medications have safe temperature ranges. Epinephrine's a good one here as well, because epinephrine freezes at about the same temperature as water. So if you're doing trips where it's the nighttime temperature or even the daytime temperature is going to go below zero, that medication needs to be stored inside the patient's jacket or your jacket as well. At night, it needs to be inside your sleeping bag with you so that it doesn't freeze, right? Some medications are sensitive to ultraviolet light. Those typically come in a dark brown bottle. So you want to make sure you're also protecting them from ultraviolet light. So maybe not leaving your clear dry bag in the sun on the beach at lunchtime when you unpack your pack, right? You might want to keep that inside your pack, right? Don't just leave it laying around. And then we have to protect medication also from moisture and water a lot of times, right? So people have gotten pretty good at that. There's lots of products out there to protect gear from water, especially I think the advent of cell phones made those kind of products ubiquitous in the market. So it's pretty easy now to protect stuff from moisture and water, but you got to pay attention to that and make sure you're doing that. Another consideration, and this one I consider, I tend to consider pain a really good example to think about this. And when I teach guides, I give somebody, it's really common where you might have somebody who breaks an arm or breaks a leg, right? And the patient's in a fair amount of pain, and you want to give them something for that pain, maybe, right? Uh, One of the first questions I would say, have you tried non-pharmaceutical ways to manage the pain, right? So putting cold on an injury, maybe stabilizing that injury so it can't move around at all. Um, you know, a lot of you guys being in the mental health profession, you probably have tricks I don't even have that support emotional first aid that may actually help cut this person's pain, right? It's pretty common that I'm sure some people in the room, not just myself, have like brought a narcotic in the wilderness before, you know, that you had left over from a dental procedure. You threw those 3 Percocets you had left into a bag and brought those, right? And then your buddy breaks his leg and you're thinking, well, he's in a lot of pain. Let's give him a Percocet. Well, I would say, you know, you want to be careful with that first and maybe try these other tricks first and make sure, because of if some putting some cold on the injury and stabilizing it ends up cutting the pain enough that it's tolerable, then maybe jumping to a narcotic is not the best idea, right? So these are things you want to think about. Does anybody have any questions about those things first? Because those apply to all medications. Everybody's happy with that? Awesome.
Oh, Doc, I was gonna say, I don't know if you can drag my video off of your screen, but there you
There you
go.
go. How's that,
Yeah.
Day?
Folks don't have to look at me, that's fine. Thanks, Doc.
There you go. Well, you did brush your hair before, so that's all right. Let's see, we're going 7 rights of medication. So one thing about the rights of medication, I'm sure some of you probably learned them when you were going through school as well. When I first went into healthcare in 1985, we had 5 rights of medication. And I've seen some nursing textbooks now that talk about 12 rights of medication. And when I read into those rights, what they've done is they've just subdivided the original 5 that I learned about, right? Because when I start talking about it, you'll see how there's more than just one thing with each of these rights of medication. The way it works in healthcare, most healthcare facilities have their own set of rights of medication, right? So some hospitals might have 7, and then you go work at a different hospital and they have 10, right? And they've just subdivided this stuff. So I'll try to I've included all the things I know about the rights of medication in here. So you can see how it works. Now, it is a risk management procedure, right? And I know in the guiding industry, we have lots of risk management procedures that we regularly practice. You know, like if you're a backcountry skier, we usually check the avalanche forecast. And then when we get into the field, we have procedures like making sure that everybody's beacon's working right there at the trailhead when you start in. And then when we get to the area we're going to ski, sometimes we dig a pit, right? And check out the snow and do the shovel test and, you know, try and make decisions in that kind of way. Well, the rights of medication are exactly the same kind of thing. It's a procedure that you kind of want to go through, right? And in the guiding industry, most of us that go out and lead trips, we're not likely to have all 7 rights of medication. There'll be 1 or 2 that you just aren't able to achieve, right? So the rights don't tell you whether or not you can give a drug, right? They just tell you how risky it might be if you are to give the drug. It just is a way to give you an idea of how to quantify that risk in some kind of way. And it is a rough quantification, that's for sure. In hospital, if you don't
Doc,
have
sorry,
all the
Doc,
right,
can I
oh,
interrupt
go
you for
for
a
it.
sec? Just
Yeah,
your
yeah.
video turned off for some reason.
Oh, really?
Yeah.
I show it as being on, but Zoom. Okay.
There you go.
Is it back?
Yeah,
Yeah,
it's
that's
back.
weird.
Sorry about that.
Just kicked out for some reason. So for example, in hospital, the way they use the rights of medication is if you don't have all the rights, you can't give the drug, right?
Oh, it happened when you dragged my video off.
Oh,
I don't know. Now you're back. Okay, we'll just leave me on. Everyone can see
good.
me while
Everybody can
you're
stare at
clicking
Dave.
through.
Okay, great. So we're fully back now. That's good. Um, so where was I? So in hospital, for example, if you don't have all the rights, you can't give the drug, right? That's their risk management policies. But in the wilderness setting, we're just using it. We're just piggybacking on these rights as a risk management procedure. So I know when I'm in the field, I'm never really likely to attain all the rights of medication. And you'll see that as we go along, why that is the case. But it does give me an idea of how much risk I might be taking. So let's jump into the rights and see what we're talking about here. So the first one, is it the right medication, right? So some of the things I think about with the right medication is, one, if it's an over-the-counter drug versus a prescription drug, right? If it's an over-the-counter drug, anybody can take it, right? Whereas if it's a prescription drug, theoretically, the only person who's allowed to take that is a person whose name is on the bottle. So if you brought your leftover Percocet from a dental procedure, just in case something happens, right? Theoretically, you're breaking the law by giving that to your buddy, right? Now, I'm not saying I wouldn't give my buddy who's in a lot of pain a pain medication, because I probably would, but I would do it knowing that I'm violating this right in that sense, right? Another consideration is allergies. Is this person allergic to the drug? You don't, if they've never taken the drug before, you don't know, right? Everybody who's got an allergy had a first time, and that first time could happen on your trip, right? If they've taken the drug before and they didn't have any problems with it before, then it's less of a chance of having a problem. Is it the right drug for the intended use? People screw this up all the time, right? Like, people will get, at this time of year, lots of people start getting seasonal allergies, right? So then they go to their medicine cabinet because they're all clogged up and not feeling so good, right? And they look in there and they don't have any allergy medication, but they have some cold medication that's for sinus congestion. And so they decide to take that because they don't want to go down to the pharmacy and get another bottle of pills. And what a lot of people don't understand is the mechanism that makes you have a clogged up nose with a cold is slightly different than the mechanism when you have an allergic reaction. So it's not likely to help you as much as you would hope, right? Now, people also screw this up in lots of other ways. So you really want to consider, is this the right drug for what I'm intending to use it for? Another thing is, what are the side effects of that medication and how's it going to affect your activity? You know, going back to allergic reactions and allergy medication, first generation allergy medication make people drowsy pretty much, like Benadryl and stuff like that. So that may affect your activity, right? If you're, say, rock climbing and your allergic buddy is taking Benadryl, but he's also belaying you while you work on this climbing problem, right? That may not be the best idea if your buddy's getting bored down there while you keep trying to figure out the crux move on this climbing route, right? So you want to be careful about that kind of stuff. And it's easy to look that stuff up. I'll show you how to do it. The next right is the right dosage, right? Pediatric dosages are different than adult dosages, right? Sometimes even what's the maximum single dose of a drug that you can take in one step, one sitting. I'm sure many of us have had what you might consider a 3 ibuprofen headache before, right? Well, can you take 3 ibuprofen in one sitting, right? You got to look that up and figure it out if you're planning on doing that kind of thing. Another consideration might be, what's the maximum of single dose or maximum daily dose that you can take, right? Lots of people, when you look at non-steroidal anti-inflammatory drugs, the directions, take 1 to 2 tablets every 4 to 6 hours as needed, is a really common set of instructions on a bottle of non-steroidal anti-inflammatory drugs, right? But a lot of people don't read the next sentence that says, do not exceed, say, 3,200 milligrams a day, right? And so a lot of times, if you take that maximum single dose every time, every 4 hours, you will exceed the maximum daily dose if you're not careful. So you got to pay attention to those kind of things, and you have to do the math, right? The right patient. So in the guiding industry, you're not typically dealing with people where you hold all the medications, but in some groups, if you have all pediatric patients, you know, all kids on a trip, or if, say, you work with programs like what used to be Coastline here, which are court mandated wilderness programs, right? The guides that do those programs have all told me that all the kids that come on those trips are taking medications, and the guides have to hold all the medications. And so, 2 or 3, 4 times a day, there's medication time, and all the kids are lined up, just like in One Flew Over the Cuckoo's Nest with Nurse Ratched handing out drugs, right? And they had to make sure people got the right medication and that they took the medication and stuff like that. And in that kind of environment, you could accidentally give somebody the wrong medication in that case, right? So you really want to be careful if you're in an environment where you're handing out all the medication and you're managing medication for the whole group in that way. So you got to be really careful. In healthcare, we give people armbands. I look at the armband, I look at the doctor's order, I ask you to state your name, and we make sure that all these things are the same before we give you the drug, right? So if you're in that kind of environment, you probably want to take a similar kind of approach, right? We have to make sure we give drugs the right way, by the right route, right? So, for example, if you have somebody who takes a pill, but there's some reason why you don't want to put their pill in their mouth, maybe they're unconscious or semi-conscious or vomiting or something like that, you might wonder, well, can we stick this medication in their butt? Well, you don't really know, right, if it's going to absorb that way. And even in hospital, if a doctor was considering that and they didn't know, they would call the pharmacy and talk to a pharmacist to see if that medication will absorb through the rectal mucosa, or is it going to cause a problem down there, right? So you really want to make sure you're giving drugs the way they're designed to be given. And if you can't give it the way it's designed to be given, either one, you can't give it, or two, you need to call for advice, right? So that's the way that part works. You have to give drugs at the right time, right? Many drugs are at set time intervals, like antibiotics. Some drugs you take at the onset of a condition. Other drugs you take, say, before, with, or after meals. Some drugs you take at the hour of sleep, right? And we could go on and on and on about this kind of stuff, right? There's lots of little stickers in the pharmacy that they put on the bottles for medications. And you just have to make sure that people are taking it at the right time, the appropriate time, and the right way, right? So people screw up antibiotics this way all the time, right? So I always tell students, imagine you're given a prescription for an antibiotic, and by the time you get that prescription filled, it's like 7 o'clock in the evening, right? And you get this antibiotic prescription, say for a sore throat, right there in London Drugs at 7 o'clock at night, and you're ready to be done with the sore throat by now, right? So you go over to the water fountain and you pop your antibiotic, right? And you look at the bottle and it says, take one every 8 hours until they're all gone for 10 days or 14 days, whatever it is, right? If you took the first one at 7 o'clock at night, when's the next one due? It's due at 3 o'clock in the morning, right? And you have to be honest with yourself here. Are you really going to wake up at 3 and take your second antibiotic? Or are you just going to wait and take it in the morning? Because if you don't wake up at 3 o'clock and take it when you're supposed to, right, you've already screwed up that 10-day or 14-day course of antibiotics on the very first dose, right? The way antibiotics work is once you start your antibiotic, if they're designed that you maintain a minimal therapeutic blood level for the whole 10 or 14 or 21 days that you're taking that medication. And that over the course of those 10 days, say, that medication never drops below the therapeutic level, right? And if you wait and take your medication at 6 o'clock in the morning when you wake up and you were supposed to take it at 3, you will drop below that therapeutic level. In fact, you may drop to 0 in the bloodstream, depending on what the half-life of the drug is in the body. So basically, you got to take drugs when you're supposed to take them, right? So want to be careful there. The right documentation. So if you're taking people out and you're the trip leader, right, you should be writing this stuff down. In Wilderness First Aid, we use patient care records when we take care of patients. And if I give anybody any medication on a trip, I'm writing it down. Even if you come up to me saying, hey, doc, I'm having a bit of a headache. Do you have some ibuprofen, right? Sure, I might give you some ibuprofen, but I'm going to examine you first, 10, 15 minutes worth of talking to you and get a set of vitals and and make sure that you're not having a stroke, right? Because, you know, headaches, a lot of people have stroke will have a headache with that stroke, right? Or maybe you hit your head and you're having a head injury, right? But you didn't tell me that you hit your head, right? We don't want to medicate people who might have a head injury because we have to monitor your headache, right? And you can't monitor a headache you're medicating. So you want to make sure that you're not messing that up. Now, I'm not saying I wouldn't give you ibuprofen. I will if you pass all my little tests here, and I'm quite convinced that you just have a, you know, a simple, say, tension headache or something like that. I got no problem with, you know, giving you some ibuprofen or any other non-steroidal or Tylenol to help you manage that headache. But I am going to make sure I'm not medicating a stroke or a head injury first, for sure, right? Um, and one way that I kind of avoid a lot of work with this kind of stuff is I tell participants on a trip that if you regularly take medications for headaches or menstrual cramps or muscle aches and pains or allergies or these kind of things, I just recommend people bring their own medication for those kind of things. That way I'm not being the group pharmacy for that kind of stuff, right? Um, and then I also tell people, look, that if you're medicating something that you normally kind of medicate, like say menstrual cramps, I tell clients that make sure that when you're medicating it, that um, it's both that the menstrual cramps are the same as that they are all the time, and they're not any different. Or your headache is the same that it is all the time, right? And it's not different, because different implies there's a different mechanism for that, or that there's something different or wrong about that, right? And if it's different, we should be seeing that person as a patient, right? And seeing, okay, why is this different? Is it different for a reason that I should be concerned about, right? And you want to be careful with that kind of stuff in that way. So I just tell clients, if it's different, come and see me. And if it's the same, you can self-medicate, you know, as per the directions on the bottle. The second piece of documentation is is knowledge about the drug, right? So that's one thing we're not just going to have, right? And so you have to have a way to look up medications in the field. In the old days, and Day remembers these, we laughed about this earlier. In the old days, I used to tell guides, you got to get yourself one of those compendium of pharmaceuticals and specialties, a big blue book, right? And I would tell you, you got to photocopy all the pages of all the drugs that are coming on the trip. That way you have drug information, right? Nowadays, it's gotten a lot easier with apps, right? There's lots of medication apps designed for healthcare workers out there. Nurses have them on their phones and doctors have them. I recommend people get an app called Medscape or Hippocrates, either one, right? And I'll show you Medscape, but it's a great way to look stuff up. So here's Medscape, and it's an app that if you download it onto your device, you have to download the clinical reference, but if you download the clinical reference for this medication onto your device, you can use it in the field when you don't have any kind of data connection of any kind, right? The nice part about Medscape too, at least for wilderness first aid practitioners, right, is not only does it have drugs, it also has medical conditions and procedures and stuff like that. So I've used it to look stuff up in the field that I didn't really know what to do about, right? And it's been super beneficial in that way. But also as a drug reference app, it's really quite good. So let's look up a drug. I looked up something recently, and let me just look up the name of it here. I looked it up on my phone, so I have to open up Medscape on my phone now and see what the name of that drug was. It was a drug I actually looked up for us here. CYM.
Oh, you got it.
Yeah, Cymbalta, right? And so I'll just show you how you can use Medscape to get this kind of information, right? So Cymbalta is an antidepressant, right? An SNRI, and it's also used for fibromyalgia, right? So if we click on dosage and indications, right there at the very top, it'll tell us all the dosages that it's produced and distributed in Canada in. And of course, there's pediatric and also geriatric on here as well. And you look down, the indications for this drug is major depressive disorder, diabetic peripheral neuropathic pain, generalized anxiety disorder, fibromyalgia, chronic musculoskeletal pain, right? And then even below that, there's some modifications to the dosages of the drug. This isn't necessarily so important to us, but if a physician had modified the dosage for a patient, if you look up here and it doesn't really make sense, their dosage for what's wrong with them, come down and look at the modification, and maybe there was a modification made by the patient's doctor because of, say a kidney problem, that would be a renal impairment or something like that, right? Then there's also considerations on the dosages too, that you might find something interesting in that applies to your patient, right? Moving beyond dosage and indications, oh, there it is, drug interactions at the bottom. And now for our use in the field, you're probably going to want to sort by name. But basically, this list of medications are medications that don't play well in the playground with Cymbalta. Was that the name of the drug? It's duloxetine, it looks like, is the name of it. Is the generic name. So all these drugs don't play well with this drug in the playground, in the body, right? So, if you have somebody say taking this medication and they come up to you and go, hey, do you have any ibuprofen for a headache? And you check out the patient, they seem fine. There's no history of head trauma, and they're well hydrated, because dehydration also causes headaches too, right? And they pass a central nervous system exam. Well, I'm going to go look in here and go, okay, is ibuprofen on this list, right? Oh, it is on the list. Look at that. So then I'd have to look up, what does it do? Let's see, either increases the toxicity of the other by pharmacodynamic synergism. Use caution, monitor, right? So, that may make you decide to maybe try a different drug instead of ibuprofen. Or maybe you decide to call a doctor and say, hey, do you think it's okay? Right? We can also maybe say we try acetaminophen for that headache. So we could go look, and acetaminophen is not on the list. We may want to go down and see if Tylenol, is on the list. Sometimes they might make a mistake, but yeah, there's no Tylenol either. So, you might want to choose acetaminophen to try to manage the headache, because it's not on this list of having some kind of bad reaction that maybe some of us, I don't understand some of the words in there for ibuprofen. I mean, I know what pharmacodynamic synergism is, but I don't know how that's going to affect anything else in this patient, right? So I might choose Tylenol instead for their headache. So that's how you use the interaction thing. Medscape even has this interaction checker, right, where you can just type in the name of the drug and it'll tell you if there's a drug interaction that you got to be worried about. So that's how you use the interaction page. The adverse effects page. So this tells us what kind of side effects does this drug have, right? And with modern medications now, with old drugs, you won't see these the percentages. But with modern medications now, you'll see what percentage of people in drug trials got that side effect, right? If you look at 23 to 25% of patients got nausea, 13 to 15% of patients got a dry mouth, right? And, as you go down, these are all the side effects of the drug, right? And then post-marketing reports, these are basically side effects that showed up after the drug was on the market. It was outside of drug trials, right? And so these are things you may also need to look up and see if, because if you have someone taking a medication and they have some kind of weird thing going on with them, right? It's always a good idea to look at the medication and see if that medication might be part of your differential diagnosis of what could be wrong with the person, right? So that's adverse effects. Warnings. So warnings are exactly as they say. Now there's different types of warnings. There's black box warnings, which is kind of overarching. These warnings apply. Contraindications are when you do not use this drug, it would be contraindicated. Cautions are just a low level warning, right? And you may want to read through these kind of things, right? When you're going to give people medication, and make sure that one, that you're not violating any contraindications, right? But also two, is there anything really I should know about this drug before I take it, right? And if you look at all those warnings, like there's a pretty fair amount of warnings regarding this drug, right? So I'd want to read through that and see if there's anything that that scares me about the medication, and maybe I should be talking to somebody before I give it to somebody. Not that I'm going to give this prescription medication to anybody who doesn't already have a prescription for it. Let's see, pregnancy tells us if this drug crosses the placenta, and meaning that if mommy's taking the drug, baby's also taking the drug. And it also tells us if it comes out in the breast milk. So if mommy's taking the drug, baby's also taking it if the baby's breastfeeding, right? So it'll tell you that in this list. And it looks like there's a pretty fair amount of reading with regards to pregnancy, right? So it's probably worth reading that. Pharmacology. So this will tell us how the drug works there, the mechanism of action, right? Absorption tells us how it gets absorbed into the body, right? Peak plasma time tells us at what point does it reach its peak in the bloodstream, right? In the plasma of the bloodstream. How's it distributed in the body? So, you know, if it's bound by proteins, how does it move around? It'll be bound to a protein. That's how it gets around inside the body. Metabolism tells us how we get rid of it, right? And then elimination often will tell us the half-life of the drug, and then of course how it leaves the body, right? So 70% comes out in the urine as metabolites, less than 1% is unchanged, right? And then 20% of it comes out in your feces. So that's how we get rid of that drug. It seems like they didn't do all the math. I wonder where the rest goes. Anyway, administration. This would be if there's any particulars regarding the administration of the drug that we should be aware of, right? So right there at the top, you can see it says swallow the capsule whole, do not chew or crush, right? It may be administered without regards to meals, so it doesn't really matter if you take it with your meal or in between or whatever, right? It does say do not open the capsule and sprinkle contents on food or mix with liquids, right? So, you know, all these kind of particulars you'll find on this kind of a page. At the bottom there, it also shows you how to store the drug, right? So excursions are permitted to 15 to 30 degrees Celsius, right? So if you're taking this drug out in the winter, then this drug should be stored in a place where it stays reasonably warm, right? So inside a jacket or something like that, maybe. Images, right now we'll see images of the drug because I have a Wi-Fi connection to the World Wide Web, but images aren't stored on your device. So if you're in the backcountry, you won't see the images, right? It'll be a blank page. So anyway, there's that's Medscape and how you can use it as a how you can use Medscape to gain knowledge about a drug that you're going to give somebody. Now, we were just looking at a prescription medication, but non-prescription drugs in there. Lots of supplements are also in there. You can look up marijuana. You can look up St. John's wort, you know, things that we don't typically think of as pharmaceuticals often are in that list as well. So, you know, you can see if those things may be a problem. The next right of medication is the right authorization. And if it's a non-prescription drug, I'm not going to have the right authorization. So giving somebody ibuprofen, even though legally I don't need a physician's prescription to give that drug, right? In a hospital, if I'm going to give a patient ibuprofen, I have to have a doctor's order for that, right? So now they've set it up in a hospital so nurses don't have to call a doctor in the middle of the night. Each separate unit in the hospital will have drugs for that unit that are kind of pre-authorized. There's a protocol when they can give those drugs without having to wake a doctor up in the middle of the night. Some big organizations in the wilderness, so that operate in the wilderness, like Knowles, Outward Bound, these organizations often will have pre-packaged protocols. So they'll have a medical director that's written for these drugs. And I know like Knowles and Outward Bound on like 30-day trips, they'll have narcotics, they'll have antibiotics with them, right? And those are prescription only medications. But the protocol will say when they can use that narcotic and when they can use the antibiotics, right? It'll be very specific about when they're allowed to use those things. So that's one way to achieve authorization. But smaller guiding companies, like most of the ones I work for, they're not big enough to have a medical director that writes all these kind of things for them. So in my case, I'm not likely to have the right authorization. And I just understand that, right? Going into the process. So this isn't a right. I didn't intend to show you guys this, but I'll go ahead and show it to you. We just came out with a new cheat sheet for Slipstream Wilderness First Aid. Our new map is out within the last year. And one of the things I noticed in 20 years of teaching Wilderness First Aid was most students weren't really using it. I felt like they didn't really have a functional way to use the rites of medication in any way that made much sense to them. So I made up this little calculator that basically summarizes the rights and a couple other things to help them think about drug risk management or medication risk management in the wilderness. One thing that's important to understand about this little calculator I made is not everything on here is going to actually carry the same amount of weight with regards to risk management. And there isn't really a way to do it so it works for all medication patient situations, right? Different patients and different medications will have different amounts of risk, depending on what the drug is, what the situation is, who the patient is, right? So there's not really a good way to make a good calculator, but it's meant to be an exercise that makes guides kind of jump through this hoop and think about it. And that was the whole intention in the first place, right? Let's imagine a narcotic. You brought some Percocet in the wilderness, a buddy breaks his leg, you're managing it. Your buddy's still in a lot of pain, even after putting cold on the injury and stabilizing the injury. And you're thinking, okay, maybe it's time to give him a Percocet, right? And you decide to use the rites of medication to try to help you decide how much risk you're taking, right? When you give that medication to somebody. So, if we go through the calculator with this Percocet that we had left over from something, one, is it the right? So what you do is you write a 1 for yes and a 0 for no, right? So is it the right patient? Confirm patient's name with that on the patient care record and with the patient itself. So yeah, that's easy. But is it the right name on the bottle if it's a prescription drug? So no, I do not have that right. Is it the right time? Well, it's a pain medication. And looking over here, my buddy seems to be in a lot of pain. So it is the right time. Is it the right medication? So then I would look it up and make sure that, it is the right medication for what I'm trying to treat. So I'm trying to manage pain. I would have to check Medscape and make sure that any other drugs that are on board with my patient, right? Drugs or supplements or things like that, that it's not going to be a problem with that. I would definitely want to make sure my patient's not using recreational medication and we're mixing that with narcotics, right? And then I would ask my buddy, have you ever had Percocet before, right? And if your buddies had Percocet and they're not allergic, right, then maybe we can say that we do have this right? Is it the right dosage? So you'll want to confirm that with Medscape and make sure that your dosage that your dentist gave you after you had your wisdom teeth pulled out, right, is appropriate for somebody with, moderate to severe pain, which I think is probably what Medscape says Percocet is for, right? So maybe we do have that right. Is it the right route? Well, my buddy's awake and conscious and it's a pill and they're going to take it orally. So that's not going to be a problem, right? Right authorization. Well, right away out of the gate, I'm not going to have that on my trips. Some of you might be able to achieve the right authorization, but I know I can't. I could try and call a doctor and get a doctor to give me permission to give that medication, but calling a doctor and getting doctor's order from the wilderness, it's not going to be an easy process, right? Because for a physician to give you a doctor's order, they have to trust in your evaluation of the patient and that you're not missing anything that's going to end up being a problem. Because if that doctor says, okay, yes, give him 1 Percocet, right? Now you're working under the doctor's license. So if something goes sideways, that's on the physician. If something goes sideways with the drug, that's on the physician, right? So you got to have your ducks in a row if you're going to call and get permission from a doctor to give a drug. So again, authorization, I'm not likely to have. Right documentation. So as long as I consult drug information and as long as I document it on the PCR, patient care record, then I can assume I have that right. The other two things aren't rights, but they're things that we've always talked about with medication at Slipstream and think they're really prudent to think about. One, am I treating an existing medical condition as directed by the patient's doctor, right? So here, that's not the case, right? Because my patient broke their leg. This wasn't something that they saw a doctor ever before, right? So I'm not likely to do that. But if I did have a patient, say, taking this Cymbalta drug, that would have been prescribed for them, right? And so in that case, maybe I could say yes. Will the patient's health likely deteriorate without the medication being considered? Well, pain can cause problems, right? Pain contributes to shock, to psychogenic shock in people, right? And so trying to at least cut that pain is not a bad idea. So in that case, I could maybe even have a case to say that, yeah, the medication, not giving the medication may actually cause a deterioration in my patient's health, right? And when I look at this and add up everything, so I got 1, 2, 3, 4, 5, 6 out of 9 rights, right? And if I'm happy with that percentage as far as risk management with, then I'm good to go. And if I'm not happy with that number, it may make you want to go back and look at the rights that you don't have and then try and decide if you're comfortable giving the drug or not, right? Or maybe it causes you to decide, look, I'm going to call a doctor. I'm not super comfortable with 6 out of 9, right? And that's fair too, because in the legal world, right, if something were to happen and there was a lawsuit, you might be determined to be at fault, right? And we all might have different levels of comfort with regards to giving medication. So, it's totally fair if you decide, no, I'm not comfortable with that much risk, and you decide not to give the drug in that case, right? So, all right, I'll stop sharing my screen so I can come back into the room with you here. There we go.
There's a good question in the chat.
Oh, sure, I'd love to hear it. Yeah.
Yeah, Don asked, would you inquire of any history of opioid use at some point in the rights, in this case, or just go with the benefit versus risk in this case? I don't know,
Um,
if you want to expand on that?
if yeah, it'd be a good idea. It's not something often I think about because I'm not a mental health professional. But and if it's a buddy, you kind of know your buddy, and you kind of hopefully you know him well enough to know if this person's had these kind of issues before. But if it's somebody new to you, it's probably a really good idea to ask, if you have a history of opioid use, or is this, I don't want to just assume it's going to be okay for you. I definitely want to ask, right? And hopefully patients are with it enough and hopefully intelligent enough to go, look, I can't take that. I've had problems before, let's try some ibuprofen, right? Or something like that. So yeah, definitely a great idea. Yeah. What are other ones there? Oh, Epocrates. Terry Dipple asked about what the other app was. It's called Epocrates. When I first got them, I got both apps and I played with both of them. And the one that seemed to work best with my head that I just kind of naturally chose is the one I kept, right? Because if you put both on your device, you're going to take up a lot of space because they're not small apps when you download the clinical reference, right? So I've used Medscape now for probably, I don't know, at least 10 years, maybe longer even. And I've used it tons, right? So let's see. Hattie asks, does a duty of care affect having a medication that could be helpful but deciding not to use it? It sure does, right? Because if you have a duty to care, your legal risk is actually lower, right? So if you have a duty to care, legally they have to prove negligence in court. Whereas if you don't have a duty to care for people, you're like a good Samaritan. Now they have to prove gross negligence, right? So it's a lower bar in the sense of when you have a duty to care. Most people, I do like to mention when I end up going down this rabbit hole of negligence versus gross negligence, most people seem to think that gross negligence means you were really, really negligent, right? Because you think of the word gross as being a lot or big, right? And that's not legally what it means at all, right? when you think of negligence, there's four things to prove negligence in a court in Canada. One, you have to have a duty to care. Number two, there must have been harm done. Number three, the harm that was done by you, by act or omission. So either by something you did or something you failed to do. And then number four is your performance was below standards, right? Well, in the outdoor industry, your standards are going to be, you're going to be compared to other people that do similar programs to you. So if you're a kayak guide, you'll be compared to kayak guides, right? If you're a mountain guide, you'll be compared to mountain guides. You know, if you're an outdoor educator, you're a teacher that has an outdoor ed program, you'll be compared to other similar outdoor ed programs, right? And in your world, it would not be any different. If you run some sort of mental health program, taking people out, you'll be compared to similar programs as well, right? And with gross negligence, in the case of being a good Samaritan now, right, you don't have a duty to care, so that's off the table. But the other three things still exist: harm done by you by act or omission, and your performance was below standards. But the interesting thing about the standards now is that your standards lower, right? Because your standards are, you're compared to anybody else on the planet that's walking around, right? So what would they have done in the same kind of situation? So that's the difference between gross negligence and having a duty care negligence. So would that affect my decision to give a medication? Sure, it would, to some degree, depending on what medication I'm giving to somebody. It would definitely play into my brain, right? So we all have a different comfort level with regard to risk management, whether you're skiing or climbing or legal risk management. If you have a duty to care, that always plays into stuff, right? We use waivers or a way to manage the legal risk management, right? So any other questions about the rights of medication?
I've heard sometimes with the rights of medication that one of the rights that sometimes is added is the right to refuse a
Yep.
medication, which I quite like. For those of you who are or have taken a mental health wilderness first aid course, sometimes we talk about stages of change and, okay, how willing is the person to, make a change or to take the medication they're supposed to be taking or whatever. But I think where this comes up fairly frequently in my experience as a guide is with medication vacations, which I think you had in mind to talk about anyway, but I wonder if this is a good time to talk about it, right? When would a medication vacation, I am sure we can all imagine times where it might be appropriate to look at an evacuation versus could we keep this person in the field? What would be the implications?
Yeah, it does. So medication vacations are definitely common with kids, from what I hear. I'm not an outdoor educator in that sense, and that I don't lead kids trips and stuff like that. But I hear stories all the time of, you have kids that say take ADHD medications when they're in school to, be able to perform in school and stay focused and all this kind of stuff. And then they go to a summer camp over the summer and their parents think, well, they're not going to school, so we should take them off this drug so they're not zombies on the summertime trip. And of course, I always hear from guides that lead these trips, they're like, why do these parents do this? Right? Because now they're fighting that same battle that the teacher was fighting. But now you're doing it in an environment where people can fall off a cliff or drown in a lake when you're canoeing or something like this, right? So parents do it all the time. So you definitely, if you're leading kids trips or even with adults, right, you need to, medical forms are really, really important to suss this kind of stuff out, right? And have these conversations before the trip, that this is not the ideal time to stop taking this medication or that medication, right? Now, you also have to look at what's the purpose of your trip, right? What's the goal of the trip? In my case, it's recreation, right? It's to go see some cool places and do things that people maybe wouldn't do on their own, which is why they're hiring a guide. But in your guys' cases, if you have a mental health outcome that is kind of your goal of your trip, right? You need to consider, how does this medication or medication vacation, right, play into that outcome, right? And I tell people on trips, look, coming on a trip is not the time to quit drinking coffee, or like people even do stuff like that, believe it or not. And then they come on your trip and they don't poo for 5 days and they got belly aches, and that's a problem, right? So, even something as simple as, yeah, I really need to get away from the office and I'm going to take this as a time to quit smoking or something like that. And I'm like, that's not what this trip is, right? Like if you want to have a quit smoking trip or a quit ADHD medication trip or a quit coffee trip, then that should be designed in that way so that we can manage the fallout that happens as a result of that medication holiday, right? I'm sure one or two of you have had medication holiday issues. Daniel's shaking his head here. Did you do some outdoor ed, Daniel? I don't remember your history.
I've done a bit of outdoor ed. I was laughing because I paddled from here, or from Vancouver Island up to Prince Rupert, like a month-long trip a couple years ago, and I decided to use that for the first time in like a decade and a half to stop drinking coffee. But I did it to myself. So that was totally on me.
Yeah.
Yeah. Oh, it was all good.
Yeah. Legally, they'd say you contributed to your own negligence, right? Any other questions on any of the medication stuff? All right. So what I'd like to do, so I wrote up a scenario. I thought there was just a good example of give you guys something to talk about, and a good example of using the rights of medication in real life. And so I thought I'd throw it out there. So what I'd like to try to do, how many people have taken Wilderness First Aid before? So either 40 or 80 or 90 hours of Wilderness First Aid. So let me write your names down a sec. Terry and Heidi and Janet and Daniel, of course I know, and Hattie. Great. Oh, and Zoe. Wow, lots of people. Awesome. I just want to make sure that I'm going to set up a breakout room, right? And the way it's going to work is I'll take a select person out of each group and have you guys wait in the main room, and everybody else will go to the breakout room. And what I'll do is I have a scenario that I wrote up on Google Drive, and I'll post it in the chat for the people that are still in the main room. And you guys do a quick read through it. We can do that kind of together. But then you're going to go to your group and you're going to present the scenario to the group, right? And the reason I asked about people having wilderness first aid training was only because the process of first aid, it's kind of written in a process kind of way. And Day has a process in mental health wilderness first aid that parallels this very much so, right? So that way I know that at least each room has somebody who's experienced with the process, right? And that way you can think through it in kind of the same kind of a way. Does that make sense to everybody? So you don't have had any wilderness first aid training to do the scenario, right? But it does help if you've had some to think about it in a procedural kind of a way is all. So it'll be, Day, can you, let's see, maybe we can do 3. We have, let's see, how many people do we have, not counting me and Day?
And I will say, folks, like I said earlier, but some of you weren't here. If you can't participate out loud for some reason, you're in a public space or something, please do stay on. Don't feel like you have to log off at this point. You can just observe. But maybe we'll spread you out so that, each room at least has some folks who are able to participate openly.
Yeah, and the scenario is just designed to illustrate some of the stuff I was talking about and how you can use the rights maybe to your advantage, right?
I was hearing great discussion. I think the thing that I liked the most, my little takeaway, was that, in the midst of all this discussion, I heard Terry say something about, why don't we just see if we can sit down and have a conversation and talk about some of this anxiety and see if there's anything to get off this person's chest. And in Mental Health Wilderness First Aid, for those of you who've taken a course, we talk about the relationship as the foundation of all other mental health work. And so I was really just happy to hear that. And then there were lots of other good notes from folks as well, looking at the link between different substances that might have been interacting. But yeah, Doc, what do you want to say? We got about 4 minutes.
My curiosity was, did anybody actually look up the medication on Medscape And did you find an interaction that might have been contributing to this problem, right? So what was that? Anybody want to pipe in? Sure, Don. Oh, the smoking. That's right. Right. So now cigarette smoking probably on one level was helping this person with their anxiety, but it's also decreasing the effect of the medication that they're taking for the anxiety. So, are they stabbing themselves in the back? I mean, there's no real way to quantify that, but that could be part of your discussion that you have with this patient. Say, hey, look, in drug trials, they found this out, right? And so maybe we should put your cigarettes in my pack and see if we can help you through this in a different way or something. That's how I would approach it. But maybe you guys have some other ideas, right? Yes, Zoe, would you guys come up with, or
Well, I was wondering, on
Dawn?
Medscape, it says tobacco use will decrease the level or effect, but I wonder whether that's for tobacco itself or like as a complex compound or specifically the nicotine that's affecting it, because then you could potentially use, like the history had said there was a history of trying to quit and using like the Nicorette packs, I think. So
Yeah.
like that might be an alternative if it wasn't the nicotine that was causing it. But like it doesn't specify that. So we don't know unless we contact someone.
Yeah, exactly. And I noticed the same thing, Zoe. Like I looked up to see if nicotine was on the list itself. And I have seen nicotine on other lists in Medscape. So, maybe it's the complex effect of smoking that actually is causing the problem, right? There'll be some sort of biochemistry that's going on in the body that's making the medication less effective because of smoking. And so we don't really know. I would have hoped that the patient's physician would have known that they were smoking and using Nicorette and made a good medication decision based on that. But even physicians make medication errors all the time. I've seen nurses catch them in the hospital all the time where you have drug interaction problems, right? So, anybody else have any interesting things they came out of that with? Can't hear you, Janet, if you were talking.
No, it's a good one. I was on Medscape. I hadn't quite gotten down to. I noticed that smoking and tobacco use were both indicated, like contraindications to this.
Mhm.
And it explains a little bit by affecting hepatic enzyme metabolism, right? So, it just does not allow this patient to use the drug effectively. And so we hadn't gotten to the Nicorette though, like the quitting tobacco. We hadn't gotten that far yet. So
Yeah.
that's interesting. Yeah.
Rudy, did you almost say something there too?
Oh yeah. At the end, right at the end, name slipped in my mind, but we mentioned sleep. We didn't ask whether or not they were getting enough sleep. So yeah, that's it.
Yeah, and then of course wilderness activity, right? People have different comfort levels, and if you do it all the time, like I'm really comfortable outside. In fact, I'm more comfortable in the wilderness than I am in the city, right? Personally, and I'm sure some of you are smiling. You probably have the same kind of feeling, right? So, but other people, the people that you're taking out there, don't have the same comfort level and the activity that you're doing. If you're canoeing, maybe somebody has is really concerned about water, or if you're climbing, people are scared of heights, and like all these things ramp up people's anxiety. I remember as a kid, like I was a really picky eater, and I hated going to other people's house for dinner because I'd be afraid of what we were going to have for dinner and that I wouldn't like it, and things like that. So people would have these same kind of things, and it could be, in his case, it's probably multiple little issues that are kind of ramping up, right? And of course, that's what caused him to go back to smoking. And he obviously had some concerns about his anxiety pre-trip, because otherwise he wouldn't have gone and brought a carton of cigarettes with him, gone back to this teddy bear of his cigarettes, right? So, it it doesn't open a lot of potential doors, right? Of discussions that you could have with this person. So anybody else find anything kind of interesting or cool? There's nothing else hidden in there, just in case you think I'm trying to, that there was something else nobody's finding, you know? So.
Oh, I was gonna ask, is there anywhere that you would recommend that anyone might go, including, you know, I'm thinking myself as a counselor and a guide, if we wanted like a basic introduction to pharmacology, for instance, just to have a basic level awareness of what classes of drugs there are, or like how to understand different drug names, like, you know, any kind of basic level awareness?
That's a great question. I don't know of one, but now that you asked it, I'm gonna write it down here, and I'm gonna look for something that I can add to our online campus to give
Yeah,
people
yeah.
something like that. Like I know in our online campus, I have a basic anatomy and physiology where I try to make it as simple as possible to give people a little bit of a foundation to consider, you know, with regards to first aid. But I definitely don't have a source for pharmacology. Pharmacology is pretty, like, it's not an easy degree to get, right?
Mhm.
Biochemistry is difficult. And I always make a joke with guides. I'm like, look, you know, there's a reason we went into guiding. It's probably because we didn't do good at chemistry, because chemists make a lot more money than guides, right? I'm sure they make a lot more money than mental health professionals as well, right? So you know, I try and, you know, try to keep us humble in that sense, right? That our knowledge isn't awesome. And of course, the pharmaceutical industry, they just want you to buy this stuff. So they're not gonna help you out too much in that way, right? So, you know, by making medications, by normalizing them so much in society, I used to, when I used to see patients in the Navy, I had people that got upset because I didn't write them a prescription for something when they went to the clinic, right? And it's not that simple. People, the average patients don't understand those kind of things, right? So, and I tell guides, look, we don't understand it either, and you need to you need to stay humble with regards to this kind of stuff, and don't be cavalier about medications in the wilderness, right? So.
One of the things we said if we were able to is contact the doctor and let him know what's going on. And Don had said maybe his carton of cigarettes fell in the water.
Yeah,
And
exactly.
he's like, "Oh my God, I'm gonna smoke!" Right? But, yeah, but we had said too, like did he take it? And then the answer was, yeah, he did take it, but just basically like if it was his comfort level, right, of being in the woods and that. Because like you said, like a lot of people aren't used to being outside sometimes, you know?
Oh, for sure.
Yeah.
Yeah. And I mean, if he felt that strong about his cigarettes as a guide, I might offer to take half and put it in my pack for him, because I don't run quit smoking trips, right?
Yeah.
So as long as we don't have a wildfire risk that I'm concerned with, you know, if you need those cigarettes to manage your anxiety or whatever it is you're doing with them, then I'm happy to help you out in that vein, right? Because but definitely nowadays, gosh, the fire season's already started, right, out here in Western Canada.
Yeah.
There's also the factor of the other people. It was immediately mentioned that the people on the trip were getting upset about the tobacco use. So it would be addressing what's happening with the anxiety and the tobacco use, but also if the client's going to continue using the tobacco, setting some guidelines of like, you're not going to be smoking in the bow of the boat when there's somebody behind you. You need to be this far away, and this is what you do with your butts, and here's how we maintain, you know, as safe a camp as possible so we don't start a forest fire or make everyone else in the group have a miserable trip.
Exactly.
I've got a question, and I don't know if there's necessarily an answer to it. I'm just curious, reflecting as we've been going through these conversations. So I took out an adults trip a couple of years ago. And I found out this information after the trip, but I'm just wondering maybe how we could approach it differently in the future. But one of the participants who was on this trip had told us they were taking multivitamins. It turns out they were actually microdosing on the trip, but they were concerned that they wouldn't be able to come on the trip if they told the organization that that's what they were doing. But it was like a part of their mental health routine or whatnot that they wanted to keep taking it. So I'm just thinking, as we've been talking about drug interactions and things like that, obviously, like with adults trips, like adults are going to do what they're going to do. But that makes it difficult for us as guides, because, you know, then you're on trip and you think someone's taking multivitamins. So, okay, this doesn't have an interaction, but then you actually find out, you know, they're microdosing something, but you might not know. So I don't know if it's so much of a question or just like just like a ponder of how we navigate that, I guess.
Yeah, you have to, wherever you work, you have to have policies around stuff like that, right? And you have to, so not being a mental health professional or a pharmacist, right? I don't know if microdosing is going to increase the risk of our activity, right? Like, I don't know how that affects that person. I mean, when we look at society, right, we're wrestling with legalized marijuana right now, in the sense of like, what does the RCMP do about it, right? So we don't have a roadside test for marijuana. So, you know, like, how much is too much to drive or to do these kind of things? And, you know, it happens on trips. People come here to go on a kayaking trip and they hit the dispensary on the way because they feel like it helps them enjoy their wilderness experience more. Or maybe they're using the marijuana medicinally to try to manage, you know, some sort of issues that they're having. And then how does that affect the trip? Because if somebody's using recreational drugs and then we dump a canoe and somebody drowns, right? And, you know, maybe somebody, if you think about it this way, maybe somebody in your canoe is using recreational drugs on the trip, and then they dump the boat and somebody in that canoe, not the person using drugs, drowns, and then there's a lawsuit. That's kind of a sticky kind of place to be, right? If you're in a court and you learned that this person was microdosing psilocybin, right? You know, that's not going to look good for you in court, right? So how do you manage that kind of stuff? And does microdosing actually affect people's reaction times and things like that? I don't know what the answer to that question is, to be honest. So, and where do people cross the line where it actually increases the risk for that individual, for the group, for the guide, it's an interesting question, Heidi, because how do you manage it, right? Like currently the places where I work, there's no recreational drug use on trip. That's just our rules. Alan could actually speak to what OB's policy is regarding recreational drug use, right? And then, you know, microdosing, of course, is not necessarily considered recreational drug use in that sense. So how does that apply? Alan, would you have any sense of any thing you could tell us about OB's policy regarding that stuff?
Yeah, and I mean, it's become an interesting discussion, especially around legalized marijuana, and saying that these are things that you can't, and also you know, as you talked about, it might be a medicinal thing. It might be prescribed for you too. And so
that's right.
Those are lots of different layers to kind of look at it from, but we have a no use policy. You can't bring it on our courses. And everyone signs an agreement to that. So it's laid out in a pre-trip document of these are the things that you know, you can't bring alcohol, tobacco, these drugs. This is how you're going to be, you know, you have to, it's just an agreement that you make and that you sign into before you enter the trip. Doesn't mean we don't have people bring those things. You know, definitely in the last few years, marijuana, mushrooms, all those things have been taken away from participants at some point.
Yeah, it's super interesting. And I think we just don't know what the answer is yet. Like, society has to wrestle with this and come up with some sort of decision, right? So I'm fascinated by it, Heidi, to be honest. Like, I love these kind of discussions because, there really isn't a right answer that we know yet, right? But the only way we're going to come to an answer is we all got to start talking about it. And, we can't just turn our backs and know what's happening, right? You have to manage it somehow. And wilderness trips have risk. If you're on the water, there's a drowning risk. If you're climbing, there's a falling risk. If you're right. And so you have to manage it somehow. And lots of trips have lots of alcohol in it. Most raft trips, like big rafting trips and stuff like that, they have a raft dedicated just to the booze sometimes. Like it gets kind of, in a way, out of hand in a lot of, I know heli skiing, there's incredible amounts of recreational drug use in the heli ski industry, right? So it's really quite fascinating to me.
It's probably worth noting too that even if you are microdosing and you're used to the microdose, and it's usually like a subconscious effect on you, if you get yourself into a situation where your physiology or your nervous system is stressed for some other reason, or there's some kind of trigger on trip that's making you feel anxious or something like that, that can become suddenly it has a more pronounced effect on you just because of the psychology of it.
Yeah, it's cool. I look forward to seeing where all this goes, right? Like, hopefully I'm alive long enough to see where some of this goes too, because, microdosing and using what we were formerly just recreational drugs and illegal drugs, right, are becoming much more mainstream now, especially in the mental health industry, right? So, yeah, I'm fascinated to see where this is going to go and how we're going to come up with some kind of management for it. I don't know what the answer is.
Yeah, it's another very gray area, but one that is definitely in full swing in some parts, including Comox Valley and Vancouver. There are mental health facilities that are, using psilocybin, and that's becoming part of the discussion.
Yeah.
I think for, the interest of time and just not having a kind of a trail off ending, and maybe we should have a formal ending. Well, thank Doc very much for his time, and this has been a fascinating discussion. I didn't even notice an hour and a half just flew by. That was wonderful. So thank you so much for that. We are chatting in behind the scenes about, can we do more with this topic and maybe integrate it into the 40-hour course more. But anyway, I'd like to say thanks very much, Doc. If folks have any questions, or if they want to get in touch with you or Slipstream, what's the best way to do that? And do you want to drop a link in the chat or
email is the best way, and I'm certainly open to questions and those kind of things. Let me drop it in the chat here. I keep clicking the wrong button here. You'd think I don't use Zoom all the time, but I, believe it or not, I actually do. Where's the chat here? Oh, there it is, right there. So yeah, I'll just drop my email in. You're welcome to drop me an email if you have questions or comments or those kind of things.
Yeah, and Slipstream does great
Wilderness
first aid training as
I
well.
spelled first aid wrong. Huh. I'm a hell of a first aid instructor when I can't spell it. There we go. That looks correct. Awesome.
That looks good. Great. Yeah, well, keep in touch, everyone.
Right
thanks for being here. And again, we
Thank
really
you,
appreciate your time, Doc. This has been fascinating. And to be continued. Next guest speaker is coming up May something. We've got a clinical counselor and a search and rescue member coming in to talk to us about neurology and rewiring the brain through connection to nature. So looking forward to that one. She's a former student of the course too. Mm-hmm.
Right on.
Yeah, keep in touch, everyone, and we'll see some of you on Saturday if you're in the Saturday course. See you guys.
Thank you.
Thanks, Doc.
Thanks for everything. That was great.
Yeah, awesome. Nice to see you again.
Most welcome.